coordinator here at Lancaster EMS, and I want to welcome you to the Sensory Prepared presentation. Sarah Griffith is with us tonight. We are doing a little bit differently for us. We have our EMT Academy in the room, and then we have you joining us online as well. I'll let Sarah say a few words about herself, and then we can get started. So it's all yours.
So for everyone online, they pretty much know who I am. They're either my coworkers or other people that I've interacted with routinely. However, if you don't know who I am an AEMT here full time. I'm also a mother to an autistic child, and with having a child with autism came an adventure that I definitely was not prepared for. And part of that adventure was all of the medical issues that also come with having a child on the spectrum with conditions and things like that. Unfortunately, the first 3 years of my son's life was very difficult. It was filled with lots of ambulance rides. It was filled with ICU time, as well as many other conditions. So for me, this became something that was more than just a job. It became something that was personal to me at that point. And this program was created on the foundation that I was a mother to a child who was mistreated by some crews because they didn't know how to interact with him. Not because they were trying to be bad people or because they didn't want to do their job correctly, but because treating children with autism or treating adults with autism or any of the conditions that are under the autism spectrum is a very difficult situation to be put in. And unfortunately, even though it is in our textbooks and we learn, the amount that's in our textbooks is not nearly enough to prepare you for what you see on the truck. And out in the real world, as much as we learn in the classroom and those books are helpful, they are a foundation for things that you're going to learn and experience on a truck. So this is the Sensory Prepared program that was recently approved by the state. The National Federation is also very much in support of this program, and hopefully within time it will end up being a requirement for most EMS agencies to have the equipment on the truck and the education. I have presented this specific class at multiple different agencies. One of the other agencies in our area that is also participating in this program is Northwest. So here shortly you will see Northwest EMS have almost the identical decal that we have on our trucks, if not the identical decal. And that just means that all of their providers have the exact same training that we're doing here tonight, and that they have the same equipment we do to be able to care for these patients. So like I said, this is just kind of the overview. We're going to go through sensory processing disorder. We're going to go through autism spectrum disorder and the umbrella that is labeled as autism spectrum. So a lot of people use, oh, I have autism, or my family member has autism as a single diagnosis. But ASD actually is an umbrella of multiple different diagnoses that you do need to be aware of, because for some patients, their caregiver or parent may just tell you they've been diagnosed with ASD. And there's multiple different conditions that can be, and you need to be aware of those conditions and have that running through your head while you're treating those patients. So sensory processing disorder. Sensory processing disorder is a condition where the brain has trouble receiving and responding to information that comes through your primary senses. This disorder is commonly seen in developmental conditions with the autism spectrum disorders. Sensory processing disorder may affect one or multiple senses. The person can be over-responsive or under-responsive. When we use the term over-responsive, we think of people that are very hyperactive, very responsive. When you say something funny, they're the ones that are normally laughing a lot more than you would expect for that comment. Or under-responsive can mean that you say something and they want nothing to do with that interaction, so they're going to shield themselves when maybe you only asked a basic question. And what I mean by the fact that it can affect one sense or multiple senses is, for some children on the ASD spectrum, maybe their sight and their hearing is affected, but they don't mind touching things that other children don't want to touch. So you have to keep that in mind, that sometimes it's not just one sense, sometimes it's all of them, sometimes it's one or two. So common symptoms of sensory processing disorder. These are the most common that we see. Lights are too bright and sounds are too loud. Those are the two very most common that kind of everyone hears routinely, and those are something that you need to be aware of. Soft touches feel too hard. So that one really becomes relevant when you're making contact with a patient or you're taking their pulse. If you even touch them lightly, they might pull back and say, ow, because even though you're touching them lightly, it still hurts them for them to have any kind of touch. Poor balance or clumsy. I can attest that my child has this one. I think we have fallen more times than I can count. He has bruises all over him. Most of those bruises are on his legs, but don't always just assume that if a child has lots of bruises, don't always just go down the abuse spectrum. Take a second and think about it. Are these bruises that are consistent with that child playing and just being clumsy and falling a lot? They're afraid of moving objects, therefore please move slowly. Don't just pass the monitor to your paramedic or take a blood pressure. Don't move very quickly, and keep that in mind. Clothing feels scratchy or itchy. They don't like the way textures feel, and clothing always has a texture. And they dislike slimy or gel textures. That will become relevant as you guys specifically, as you guys start to interact with paramedics. But for everyone that is a paramedic, they can kind of immediately go to where my head goes, which is all of the electrodes we put on patients. So sensory meltdowns. A sensory meltdown is a fight, flight, or freeze response to a sensory overload, and it is often mistaken for a tantrum or misbehavior. The child will stop the meltdown once they get the desired sensory response or sensory outcome. But a sensory meltdown will not just be by giving in to the child. A tantrum is a willful behavior. A meltdown can occur without being told no and has no impact on a reward system. So where this really becomes relevant is when you're going into a scene or you are dispatched for a child that is aggressive, throwing things, maybe screaming. Take a second and think about this. Are they having a meltdown or are they having a tantrum? Tantrums are what we see with a lot of the kids in the ice cream store or at the toy store because mom and dad said, no, you're not allowed to have that. A sensory meltdown is what happens when a child hits the point that they are past a cognitive ability for reasoning. You are no longer able to reason with them because they need some sort of sensory fix. So one of those big examples that I use is my son. When we go to the grocery store, if it is a very busy day in the grocery store and there's a lot of commotion going around, my son is triggered sometimes and will go into a meltdown. His meltdowns consist of him immediately becoming aggressive. He starts to cry. He becomes disobedient. And it's not because he's throwing a temper tantrum because we're at the grocery store. It's because he can't handle everything happening around him. And the only way that I'm able to solve that is by removing him from the situation. Meltdowns can manifest in many different ways. Sometimes it is outward, sometimes it's inward. Some meltdowns, the child can become completely silent. The child might curl up in a blanket, not want to be seen, not want to be touched, not want to have any interaction with you. That is a meltdown. But you have to understand that most of the time, once they've hit that meltdown point, they are past any cognitive ability to reason with that. So you need to be the one to try to figure out what it is that they need. And that's where the parents and caregivers become a huge support system to you because they know those little signs. They know what those patients are looking for. And most of the time, that's going to need to be handled before you have any ability to figure out why you were called or what you need to do as a provider. So ASD disorders. The main 5 disorders, and there is only 5 that is recognized at this point, is autistic disorder, Asperger's disorder, pervasive development disorder, Rett syndrome, and childhood DD. It is possible to have more than one of the diagnoses under the umbrella. It is uncommon, but it is possible. Most children that end up having more than one of the diagnoses under the umbrella, their chart or their paperwork will just say ASD syndrome. That is it. It will not specify the specific disorders. If they only have one of them, it'll specify which specific disorder. That is the most common that I have found with most medical paperwork throughout being a provider and kind of having to dig through it to figure it out. So autistic disorder is by far the most common. Autism disorder is a condition related to brain development that impacts how a person perceives and is able to socialize during interactions and communication. Behaviors you may see with autistic patients: repetitive behaviors like hand flapping, rocking, twirling, hitting themselves, They are referred to as tics, but one of the reasons why understanding that that is a symptom of autism is because depending on how obvious it is that they're experiencing that tic, it can be perceived as seizures. I have been dispatched to calls where they thought a child was having a seizure and it is just an autistic child having one of those tics. Constant moving or hyper behavior. They cannot sit still. They have to constantly be doing something, whether it's rocking in their chair, playing with a pen, moving their hands, swaying. The concept of sitting still is not something that they understand. Fixations on certain objects, activity, and specific people. This really becomes relevant with toys. You see that a lot in toys. You see it with certain parents. You see it with caregivers. They fixate on individual objects, and it is not just like, oh, here's a stuffed animal. They will fixate and be able to tell you every Hot Wheel in their room without you realizing it. And as soon as you move one of them, they know that you touched their toy. Extreme sensitivity to touch, light, sound, and emotions on specific routines or rituals. That is very important. Keep in mind that in EMS, anytime that we are called, it's not planned. So we're destroying whatever plan or routine that patient normally has. So understand that going into those environments, they're already going to be upset because now their routine has been disrupted by us having to be called. It may be necessary for us, but they're already going to be triggered by the fact that we've disrupted their normal pattern in life. Asperger's disorder syndrome is becoming less common to hear the diagnosis. A lot of times you're just hearing patients diagnosed with ASD. Asperger disorder is something that's very important, though. It is a developmental disorder affecting the ability to effectively socialize and communicate properly. Asperger syndrome is a condition on the autism spectrum, but these patients are generally higher functioning. So Asperger patients normally are extremely smart. Don't take that as an insult if they correct you with your grammar or they correct you with little things, but that is just the way their brain works. When you talk, if you say something grammatically incorrect, they have to correct you because their brain cannot handle you talking incorrectly to them. So these are the main symptoms of Asperger's. Failure to develop friendships. A lot of these people are so smart and have such a high IQ, they would rather be locked in their room with a textbook than have a normal interaction like a high school person. Select mutism. This is something that you can see with more than just Asperger's. They don't want to talk to new people. They'll talk to their mom, they'll talk to their dad, they're normal people, but they don't want to talk to new people. Inability to empathize. That is something that becomes important if you're out there, maybe for the parents as the patient versus the child. Understand that that child may actually not be able to understand the situation or the severity of the situation because they can't have that emotion. Inability to make eye contact or forcing eye contact. Make sure that if you notice that that patient is maybe talking at the wall versus looking at you, don't take it offensively. Don't try to get them to make eye contact with you. Just understand that they don't like making eye contact, and that's a normal thing. Social awkwardness, narrowed interest, sticking to a routine, literal interpretations. That is one of the biggest things that I have seen backfire on providers. We make a lot of jokes on the ambulance when we're talking to patients. One of the most common ones is when we get patients on the litter, we make a comment of your butt crack to crack. Everybody knows what we're talking about when you set the head of the litter up. There is that crack that exists in the mattress. And we make that reference fairly often. Everyone else normally gets what we mean. These patients are incapable of that. So be careful how you're wording things. Don't use metaphors. Don't use little side-end comments. Make sure you're being very clear and specific about the directions that you need them to do. PDD, this is very uncommon. PDD refers to a group of disorder characterized in delays in the development of socialization and communication skills. These patients normally show signs as early as infancy and before age 3. This is a very rare condition. It's not common. Most of the parents that know these children have it, they will know and they will tell you when you get there because they understand how rare the condition is. However, being rare, that doesn't mean you don't want to pay attention to it. It does mimic autism and Asperger's to some of it, but it's just a different diagnosis, and there's different things that can manifest with it. Rett syndrome is very rare. There are fewer than 1,000 cases per year. The syndrome is a genetic mutation affecting brain development, specifically in girls with both physical and behavioral deficits. I know for a fact that we have one in Lancaster County that has this diagnosis, and that's because I've interacted with her on a personal basis. So although it is extremely rare, just realize that sometimes those rare conditions that we look through our book and go, oh, there's no way I'll ever have a patient with it, it is possible. So these are symptoms of Rett's. These are a lot of those medical conditions that I was referring to earlier. These are all of those medical things that are very common in Rett's. However, if you see at the bottom, I have it marked. But these medical symptoms and conditions can also be present with all of the conditions under the ASD umbrella. Patients with ASD conditions are more likely to have medical conditions as well. So just because these up here say that they're symptoms of Rett, because that is the most common diagnosis that they are associated with, specifically those conditions by themselves can be part of ASD diagnosis as well. Just looking at that board, I can see 5 right now off the top of my head without even actually looking at it that I know for a fact my son has experienced or dealt with while getting his diagnosis. So just understand that overall, that list of medical conditions are very common with children with these types of diagnoses. So CDD is also known as Heller's syndrome. It's a dissociative psychosis. It's a very rare condition characterized by late onset of developmental delays and having severe and sudden reversals in developmental, specifically language, social function, and motor skills. You will see this a lot. Unfortunately, you will see it a lot in the diagnosis happens and while they're in high school. That's when you're going to see it. It happens normally once a child has gone through puberty, and it happens right around the end of puberty, which is about high school for most people. And you'll see it a lot in the fact that you will see this kind of become a little bit more relevant because it's also similar to some of our Alzheimer's patients as well, because there are some Alzheimer patients that I've had that have also been diagnosed with this. And up until recently, I didn't know that was possible. So I had to go do my own research to figure that out. But it is possible as we get older to even have this later than high school. But normally that diagnosis starts in high school. So symptoms of CDD is expressive language skills. Being able to produce speech and communicate a message, they lose that. They lose the ability to talk. The receptive language skill, which is the comprehension of language, they lose the ability to comprehend you talking in full sentences. They lose the ability to be able to comprehend simple directions. Social skills and self-care skills, they lose them completely. Controls over bowel and bladder functions. So they really just kind of become incontinent. It's not a diagnosis that you want ever to see in a patient, but unfortunately it does happen. And there is not really a known reason why it happens. They know certain things that can cause it, but they have yet to be able to figure out why it happens, overall what really causes it. And it is not a condition that is able to be tested for when somebody becomes pregnant. It is not part of the genetic testing. They have not been able to figure out a way to do that yet. So ADHD and ODD. These are 2 conditions that are not under the ASD umbrella, although even though they're not under it, they are extremely common in the ASD community. Very common, which is part of the reason why, although they're not under the umbrella, you need to be aware of them and you need to know what they are, because it's not uncommon to have a patient that has autism or sensory processing disorder on top of one of these 2 conditions, if not both of the conditions. So oppositional defiant disorder in a child that is marked by defiant and disobedient behavior to authority figures. The cause of this disorder is unknown, and as of now, the cause is assumed that it involves a combination of genetic and environmental factors. Symptoms generally begin before a child is 8 years old, and symptoms include irritable mood, argumentative, defiant behavior, aggression, and vindictiveness. If you see the last line there, to get this diagnosis, these patients have to be presenting with all of those symptoms, at least 2 or more, for over 6 months. From the bottom of my heart, I ask you, when you go out to these calls where it says in the notes that the child or the patient you're going for has ODD, Don't just write it off as that patient is a brat, not disciplined correctly, being a problem, because there is so much more going on than that. And I can feel for some of these parents. I've been to some of these calls where parents call us because it's now 3 a.m. and that child has been destroying their home for the last 4 hours and they're at their wits' end. They don't know what to do anymore. So they call us praying that we have a solution to help. And sometimes we can, sometimes there's not much I can do. But the one thing you can always do, and please let this hit you where it needs to, is that the one thing you can do no matter the call, even if you can't do a lot for the patient, you can always do something for the family. Make them be heard. Make them know that you care. Make them know that you at least empathize with what they're dealing with. Because that is one of the biggest things we can do as providers, is make sure that even though we're caring for patients, you're also caring for the family, and don't just write them off. So ADHD is a chronic condition including attention difficulty, hyperactivity, and impulsiveness. ADHD is common in childhood but can continue into adulthood. This is similar to attention deficit disorder, but really the difference is these patients really honestly mimic autism in some ways. So there's a lot of patients that we go out for that have ADHD that may present similarly to your patients that have autism, but it means that they don't have the cognitive delays that are present with autistic children or autistic patients. So medical questions for ASD patients. These are specific questions that are more relevant to patients that fall under this ASD umbrella. One of them is, are they a flight risk? This very much matters, because if they're a flight risk, I highly urge you to not let them walk to the truck, because I'm not running with you when you have to run after them. Do they tend to become aggressive when they're upset or stressed? That becomes important. You're in a very small box in the back of the ambulance, and it's kind of nice to know if a patient's going to become aggressive with you. Are they a self-harm risk? Do they hit? Do they bang their head, biting themselves, pulling their hair out? These are common behaviors with those patients, but it matters, and we need to know if that's something we need to protect them for. Because if they're going to bang their head, that's where it becomes relevant. Maybe instead of just putting them on the stretcher, you make it a little more important to actually put a pillow or a couple blankets, and you put that padding there to make sure that they can't harm themselves. Are they light sensitive or sound sensitive? What's their developmental age versus physical age? This was something that is extremely important. So you may be dispatched for a 13-year-old patient. When you get there, mom and dad may end up telling you that that patient actually has a mentality of a 6-year-old. It's extremely important, because now while you're treating that patient, you have to realize, I'm treating a 13-year-old, but I'm talking to a 6-year-old. So how do I ask the questions that are relevant for a 13-year-old to a 6-year-old? You have to completely change your behavior, but you also have to be running through both of those ages in your mind. Because something that is relevant is most females by the age of 13, they've now started their periods, which means if that child has a cognitive ability of a 6-year-old, you're about to explain to a 6-year-old what a period is. So you need to seriously be aware of that. Are they nonverbal, semi-verbal, or verbal? Those things are important. So it may come as kind of a surprise to most people, but semi-verbal is actually the most common, where they are verbal but not verbal all at the same time. They will talk to people closest to them, but they will not talk to new people. That is considered semi-verbal. Nonverbal or verbal are the normal, but with some patients that are semi-verbal, they may only be able to communicate through an iPad or through a specialized computer that allows them to talk by pressing individual buttons. If that's the case, make sure you take that with you, because it's kind of important. What's the primary language? American Sign Language or ASD Sign Language? There is a difference. Not all patients that have ASD are able to comprehend American Sign Language. So there is a simpler version, which is labeled ASD Sign Language, which is very simple interactions of food, hungry, pain. They're very simple one-word interactions versus American Sign Language, where most things are broken up into 2 or 3 interactions. What's the primary communication method they use? Again, that's where it comes into the computer system. Do they have a confirmed diagnosis? Is this a diagnosis that's been confirmed by a developmental pediatrician, or is this something that the parents are going through the process, or is it something that the parents are just assuming the child has? What hospital do they normally receive care at? In this area, obviously that option's pretty limited around here. Your options like Sir General or the UPMC Heart-Lidditz or Ephrata. However, in other areas, that's a very important question because you may have 5 hospitals in your surrounding area. You don't want to take that child to a hospital they've never been at before unless it's absolutely medically necessary, because it's not going to be a good experience. Which sensory items do they prefer? That one is one of my biggest pet peeves, and one of my biggest things is because although we try not to take things from home into the ambulance, if that patient has a specific sensory item that's important to them, it being a fluffy blanket, it being a Hot Wheel, it being whatever, for the love of God, please take it with you. Don't make them suffer in the back of the ambulance just because you don't want to take the blanket with you. Please take it with you. It'll mean worlds to the patient. So sensory strategies are designed to address the level of stimulation to help a child reach a more optimal state of learning. So what sensory strategies are things that caregivers and parents are trained on for that patient. This is something that know what they are, know how we use them. However, you're not going to know which strategies need to be used for that specific patient. But this is something that you sometimes in an emergency might take a step back and look at the caregiver or mom and dad and go, hey, do you have any sensory strategies to help calm her down or help calm him down? Because sometimes even as parents, we need that little reminder of, oh yeah, all that training that I had in therapy sessions, I need to do that. Because in an emergency, sometimes our brains are running a million miles an hour and we're not thinking about doing this. But sensory strategies are something that are extremely important because it can make the event less traumatic for the patient, and that's the end-all be-all goal, is making that less traumatic for them. So these are the sensory bags that we have. You guys are welcome to look through them. You guys are welcome to come up and grab them for the ones that are in the classroom. Everyone online has pretty much seen the sensory bags. But one of the biggest things we have right now are noise-canceling headphones. You guys can take a look through. So noise-canceling headphones, these target the hearing system. By wearing noise-canceling headphones, a person with ASD or sensory processing disorder can eliminate most of the background noise and reduce what remains to a manageable level. This makes it possible to concentrate on other tasks, relax, play games or others, and many more activities that are normally difficult or near impossible. So these become very important in the ambulance. The headphones that are specifically in the bags that we have no metal in them, which means they are approved by the hospital to go through the CAT scanner, X-ray machine, and MRI, which means they're extremely helpful because they don't have to come off when we're putting patients through those loud procedures. So where can these be used in relation to first responders? If the patient's in critical condition and we need to use sirens, just because a patient's in critical condition or unresponsive does not mean they can't hear. They can still hear. Consider that. Due to the volume of the exhaust fan in the patient compartment, especially because of the era of COVID, exhaust fans that I think some providers didn't know ever existed in the back of the ambulance are now required to be on at full blast at all times. And because of that, they are extremely loud. If they're loud for us, they are about 9 times louder for a patient with ASD or sensory processing disorder. Due to the volume of the oxygen or suction if needed, it does make a noise. As an EMS provider, after so long on the truck, we tune little volume things out, we tune certain octaves out, but they can hear all of that. Due to the volume of the radio or pager, this is why that's in bold and emphasized. Remember to be mindful of how loud you're being when talking to the patient as well. Because again, being in the back of the truck, we don't realize how loud we are because we're in and out of it all day long. Be mindful of how loud you are, but especially be mindful of how loud your radio or pager is. One of the things I routinely use as an example, when you are on a call and treating a patient, you want to be cognizant of what's happening around you with other trucks, but at the end of the day, you can only handle one call at a time, which means even if there is your pager's going off for another call, you can turn your pager volume down. Don't turn your radio off because you still need to be able to hear, but you can turn your pager volume down, or maybe turn it to vibrate, because while you're treating a patient, doesn't matter because that dispatch isn't for you. Bubbles and sunglasses. I will openly admit that the bubbles are definitely fun to play with on top of helping the patient, but they are a visual distraction. A lot of children with sensory issues have a high sensitivity to bright light or easily get anxious from eye contact or environmental distractions. Visual distractions work since vision is one of the most dominant in the sensory system. That when engaged can often help to calm and distract a patient. So the sunglasses really become relevant with brightness of lights inside the patient compartment. Although the halogens were worse than the LEDs, I think the LEDs are substantially brighter, which makes it more traumatizing for these types of patients in the back of our ambulances. To neutralize the sunlight that comes in through windows during transports. So although our windows are normally tinted or have some sort of screen on them, they do create a light effect while we're going down the highway. Very similar to when you're driving in your car with different trees, all of that light constantly changes. That can be very traumatic for them because the light is consistently changing and it's impossible for them to equalize that vision to one set of light. It also helps them feel that they're avoiding direct eye contact. Although they might be looking at you through those sunglasses, them feeling like they have something on their face that's blocking your eyes from directly seeing theirs makes a difference of whether or not they look at you. So bubbles can be used to prompt a patient to come outside from a space. This is a big thing with younger patients. If you're going into a home and you have to get that child out of the home after a meltdown, or you have to get them to come out to the truck with you, instead of just badgering them of, come on, buddy, come outside, go stand by the front door in front of the kid and start blowing bubbles. Let me know how fast that 4-year-old patient comes running towards you because you got bubbles. A lot of children patients will come running towards you because you got bubbles. Huh? What? The other reason is bubbles are safe to be blown in the back of the truck. They're not going to damage anything in the back of our trucks. Let the kid blow them. They can also be used, and this is one of the big things that I've actually proven a couple of times now, they can be used to slow their breathing. So that is a big thing that a lot of people don't think of. When you inhale to blow out for that little wand that's attached to those bubbles, that's creating you slowing your breathing and you're forcing it out, which means if a child is having a hard time catching their breath because they're panicked or having anxiety, sometimes requiring them to blow some bubbles or getting them interested in that, by them doing the motion of blowing the bubbles, can actually have them relax and control their breathing without us having to intervene, which is a great thing. Fidgets are a touch and tactile since the skin is the largest sensory organ. If in a hyper or hypo sense, a child can become agitated or unresponsive. Fidget toys are often used to provide sensory input in a distracting way. They can improve concentration and attention to tasks by allowing the brain to focus on tactile stimulation. Some children feel calmer if they can fidget with an object. So every bag has at least one fidget, if not two. Some of the fidgets are a little different than others. So we carry kind of a couple different fidget toys, but most of those patients have their own fidget toys. They have the fidgets that they really like. And those are why those are important. Sometimes that fidget can be as simple as a pen that they like popping the cap off. Sometimes it's a tube that they like opening and flexing and all of that. So there's all different things. So the whiteboard and marker that's in the bag is important. It can be used for conversation. Talking to kids with autism is difficult. Many of the adults take the easy way out and just avoid including them in the conversation, which I will admit I've seen many providers be guilty of. That's a mistake. Both you and the child can benefit from attempts at the conversation. It's important for us to communicate directly with our patient, no matter their age, no matter what's going on. It's important for you to try to make some connection with your patient. Don't just ask the caregivers everything and then put the patient on a stretcher and drive to the hospital. You need to be interacting with your patient and you need to be trying your hardest to do so. There is a tendency to assume that if a child with ASD doesn't respond or shuts you down, that they don't like you and don't want to talk. Unfortunately, fortunately, that is not always the case. They probably want to engage, but they might be having a difficulty on trying to figure out how to communicate with you and tell you what's wrong. So for most children with ASD, one thing I have found common is if you ask them if something hurts, they will say yes. If you ask them to point where or tell you what hurts, they're going to say my body. They generalize some things, so they're not always capable of specifically stating what hurts. So for them, they might tell you, my belly hurts. Okay, does it hurt over here or over here? They may not actually be able to tell you. So just realize that although they're kind of answering you, if they stop answering you when you start asking more specific questions, it's probably because they're incapable of answering them. One of the big things I always say is if speaking doesn't work, try writing, which sometimes that writing can be actually writing words, but sometimes it can also be drawing a diagram. Draw a little stick figure and see if the kid, if you say, put a dot where it hurts, see if they can do that. Because sometimes they don't know how to articulate to you what part of the body hurts, but sometimes they are able to mark it on that little stick figure, or they're able to draw you a picture of what hurts. So use that to your benefit. The whiteboard can also be used for deaf patients. Instead of constantly going through paper and all of the mini notebooks we carry or using tape on your pants, whiteboards are useful for that. So chew jewelry and fidget. So the chew jewelry is something that I'm a huge advocate for more than just ASD kids. However, specifically with ASD kids, one of the biggest reasons why chew jewelry becomes important is because it's an alternative to prevent them from chewing on themselves. A lot of those kids have a tic that when they become nervous, they will start chewing on their hands or their arms, or they'll start picking at themselves. That's where that chew necklace is so important, because if they become agitated enough, they may try to bite you. So use that chew toy to your benefit and give that to them. It's also bite proof. So the reason why I emphasize it's bite proof. Don't panic if they bite down on it out of anger. I have yet to ever see somebody be able to bite through it, and I can tell you I have seen adults attempt to bite through it simply to try to prove the company wrong. They are bite proof. It is food grade silicone with layer after layer after layer. There is a little pamphlet that's contained in that letter that's contained in the packet. Please do not throw that out. Make sure that that little pamphlet or letter gets to the parent or the caregiver, because that has all of the information for how to clean it, decon it, and order more. So it's important because if that child ends up really liking it, it gives that caregiver or parent the ability to go to the website and order more of them in special colors, special designs, all of that. The other thing that you can use the chew jewelry for is I specifically will state I had a call about 2 months ago where the mom had called us because the child ended up choking on a baby bottle nipple because she allowed her daughter to chew on that instead of a pacifier or something that prevented it from going down the airway. I ended up giving the mom one of the chew necklaces, and the mom has never been more thankful because the daughter would not take a pacifier no matter what the parent did. So it's extremely important. Pain scale with faces, this becomes important with these specific type of groups because don't ask them for a number of pain. They can't tell you. They don't understand the number scale. Nice thing is now in the 21st century, we use systems called ESO, and it has the pain faces on it. So it's super easy. Just keep that in mind and use those pain faces. You can also use the pain scale with faces for more than just pain. This same scale is what all of the patients that are diagnosed under the ASD umbrella use for an emotion scale. So if the child's unable to tell you how they're feeling, or you go into a situation where you're trying to figure out how they feel, that same scale is used as an emotion scale for them, so they understand what the red zone and all of those zones mean, so they can identify their emotion also based on the face, not just for pain, which is something that's useful. So de-escalation versus sedation. De-escalation should always be your first line. This does not mean that it works immediately. You may be on scene for a prolonged period of time. However, if it appears that the patient's calming down, you should continue. And before I continue with that slide, I'm going to stop there for a second. My biggest advocate with that, I understand that we have a requirement or a set goal for how long we are supposed to remain on calls and how fast we're supposed to get off scene. If it takes you 20 minutes to safely de-escalate a child or a patient in a meltdown, please take 20 minutes on scene. I don't care if that means that your pizza is now going to be cold. I don't care if that means you don't get to go to dinner or don't get off on time. None of us care, to be honest with you. I would rather you de-escalate that patient safely and take the mechanisms that are required. And one of those things, or one of the resources that you can use in that de-escalation situation, is if you are on an all-male crew and you get there and you realize that no matter what you do, that patient does not want to interact with men, pick up the phone. We have Medic 600 here. Reach out to your supervisor. See if there's a female crew. If your supervisor is one of the females, see if maybe they can come over and help. Or sometimes even picking up the phone and calling county and going, hey, this patient will not talk to me, but keeps telling me he'll talk to a police officer. I had to do it already. One of the police officers came over and talked to the child and had the child come outside and de-escalated the situation simply by me being able to pick up a phone and communicate that I needed help and other resources to help de-escalate that situation. Sedation is not a first-line technique, and this specifically goes to the paramedics that are online. This isn't really for you guys here, just because you guys are BLS. Before approaching the idea of sedation, take into consideration if you've done everything in the ability to de-escalate the situation. The other thing that I like to point out specifically with sedation is patients with autism or autism spectrum disorders have a very high rate, and it's about 56%, of an abnormal reaction to sedation. So just because of that, be very leery when you give sedation that that patient is actually going to calm down. Benadryl will almost always make them like an Energizer bunny. Benadryl does not calm them down. It makes whatever anger, excitement, all of that worse. Ativan has been shown to do that as well, which is why one of the primary sedation drugs that are used at Children's Hospital of PA, as well as Hershey for children under the ASD spectrum, is actually Versed, because Versed seems to work the best and it doesn't cause an adverse reaction, which is always something we're trying to avoid. So knowing your first due area is a big thing. Talk to your agency about a HIPAA appropriate system that's able to track addresses of special needs patients. We have what are called alerts on our CAD, which are responder alerts. You can call county or submit the paperwork to put one on for a specific address. Certain companies and certain counties have different procedures, but your supervisors can always walk you through how to do that if you feel it's necessary. Know the distance from the home and know the area around the home that the child may run to with a flight risk. This is something you should be assessing going into any call with a special needs patient or even a child in general. When you're coming into that call, look around you. How far are we from a major intersection? How far am I from a playground? Did I pass one coming in? Know that, because if that child becomes scared and takes off running, I want to know how long I have to catch them before they go to a major intersection. Or, hey, I passed a park literally half a block down. Maybe they ran there. Know your area and know what's around you. Review your company and area's procedure for runaway children. Although it's something uncommon that we deal with, we do end up assisting the police departments with it. Know what your procedures are and know how to deal with that appropriately, and know how you can help, even if that's reaching out to your supervisor and knowing where in that procedure we can actually be of assistance. Continuing the use of the bags once at the hospital is a huge thing. Inform the patient's treating nurse upon arrival at the hospital of the patient's special needs. Advocate for the best possible placement within the ED for the patient. This is something that's becoming more and more relevant. Unfortunately, a lot of emergency departments are overflowing with patients. They have 5, 6, 7, 9-hour wait times, and unfortunately, that is a situation that we are dealing with. But if you feel that that patient you're bringing in with this diagnosis is not safe in a waiting room because you feel that they will become a flight risk or start harming themselves or harming other people, you need to advocate that to the charge nurse or placement nurse so that they can do what they need to do to properly place that patient. Inform the treating nurse of the importance that the bag stays with the child, and consider giving the nurse information how to use the items. Some companies have now started printing out little information sheets that I've worked with and put them in there just to hand to the nurses. Thankfully, Lancaster General, a lot of the nurses have enough experience with these bags now. They know what they are when we bring them in, and I will tell you the nurses absolutely love them because they are thankful for any help that they have, because child life is not always available in the emergency department to help with these kids. Make sure you say goodbye. This is one of the biggest things I can advocate. ASD children can become stressed if they don't know where the person that they were interacting with went. When we give report to the nurse, a lot of times we have a tendency to give report and walk out of the emergency department. Make it a point to go back in that room and say goodbye to that child, and make sure that that child understands you're leaving, because it can be traumatic for them for you to just disappear and them not understand why there's a new change in person taking care of them. Spend the extra minute and introduce the nurse that is taking over for you. Even though you may not be friends with said nurse, introduce it as, hey buddy, this is my friend so-and-so. They're gonna take care of you because I have to go home. Phrase it in a sense that a child can understand why there's someone new now taking care of them. So these are just a review of some of the specific items that can cause sensory issues. These are a very small list compared to most of it. The simple version is every single thing we carry in our truck can cause an issue. But these are some of the biggest things that myself and other providers have put together. Some of them apply to BLS, some of them are ALS. I will say for an ALS provider, the electrode placement, my rule of thumb is 3 and done. If I put three stickers on one patient, I'm out. If they keep pulling them off after 3 times, I'm done. I'm not doing it again, because at that point it's just traumatic for them. So my thing is 3 attempts and I'm done. This is the program decal. So this is the decal that is on all of our trucks. It is also on Northwest's truck by the end of December. There's also other agencies in the area that are in the process of going through all of this. That specific decal is a decal that I created along with my sister. It is copyrighted and everything. So the vehicle that carries a sensory bag needs to be equipped with at least one of these decals. All of our trucks here are nicely decaled on both sides, which makes my OCD very happy that it's on both sides. These decals identify all the agencies that participate with the program. And the reason that I felt that that was important for the decal not to change is because while you're at the hospital, if you see other agencies with this decal and they're not treating a patient that has special needs correctly, say something. Say something to those providers, because they have the training. They know what they're doing, so say something. But it also lets everyone else know in the area that if I'm calling for help on a patient, when that truck comes up, I can almost immediately know whether or not those providers have had the education to assist me properly. So that's honestly most of the information. Like I said, this program, there's always more information getting added. This is just a very brief education on kind of a little more in depth than what our books teach us, which is why it's important to me. But if anybody has any questions, I will be more than happy to answer them. Otherwise, I will say goodnight for the night.
Anybody have any questions? Anybody online?
There's nothing else.
Did you want to show the bags?
It's Rick. Is there anyone online that has any questions at this time? I've noticed that you've been putting in your cert number. If you haven't done so already, please make sure that it does go into the chat so we have a record so we can get everybody Con Ed. Do we have any questions? All right. It sounds like there's no questions or anything. I'd like to thank everybody for taking part in this evening. Thank you, ma'am, for coming down. I appreciate it. This was recorded. We'll render it and we'll get it up onto Planet sometime in the near future. If you're waiting for Con Ed, you will end up getting 2 sessions for this, and that'll be coming within the next week to 2 weeks. So unless anyone has any questions, I thank you for your attendance. And November's session will be on situational awareness. And I will be sending out invitations and go-to links on that in the coming weeks. Until then, please thank you again, and everybody be safe out there.